Have you ever found yourself in one of those incredibly high-stakes, panicky situations?
Oh, absolutely.
You know the kind, I mean, right, your heart is just hammering in your chest, your mouth goes completely dry.
Yep, the classic fight or flight response.
Exactly. And you need to communicate crucial, like maybe even life-saving information to someone in mere seconds.
Right.
But your brain just feels like it's, I don't know, filled with static.
Oh, it is a universal human experience. I mean,
Yeah.
the cognitive load in those moments is just immense.
It really is.
Your body kicks into overdrive, and suddenly articulating a simple sequence of events feels like trying to solve advanced calculus in your head.
Yeah, out loud in front of a crowd.
Right. And the real challenge is figuring out how to bypass that biological panic.
Which brings us perfectly to today's deep dive. We are looking at a clinical training script, and it's set in a place called the Moonlight Bunny Clinic.
The Moonlight Bunny Clinic.
Yes, I know what you're thinking. The characters have these deceptively cute names. So we have Turtle, who is a newbie nurse. We have Bunny, the seasoned veteran nurse, and Dr. Bear, the attending physician.
But do not let the names fool you.
No, do not, because the medical crisis they're managing is incredibly high stakes. It's realistic, and honestly, it's a perfect case study for high-pressure communication.
Definitely. And our goal today is to put ourselves right in the middle of that clinic floor. We really want to explore the scenario to understand the clinical dynamics at play here.
Right.
We'll decode the key medical terminology for any nursing students or, language learners listening. And we want to uncover how structured communication acts as the ultimate safety net when a situation just starts spiraling out of control.
So if you are a medical trainee learning the ropes, or honestly, just someone who wants to learn how to keep a level head when everything is hitting the fan, consider this your training ground.
Absolutely.
Let's put ourselves on that clinic floor. We're going to do a bit of a dramatic reading here to set the scene.
Let's do it.
Okay, so I will play the nurses, Turtle and Bunny, and you can be Dr. Bear.
Sounds good to me.
Okay, imagine the cardiac monitors are blaring, the rhythmic beeping is speeding up. Turtle, our newbie nurse, is looking at the screen totally overwhelmed and yells out, "Oh no, Mr. Cat's numbers are changing. Bunny, help!"
And Bunny, the veteran nurse, steps in. She's calm, lowering the temperature of the room immediately. Deep breaths. Turtle. Look at the chart. He's hit the yellow zone. We need to call Dr. Bear for a clinical review. Do you have your ISBAR ready?
Turtle takes a shaky breath, looking at her notes. "Hey, I think so." And she picks up the phone to page the doctor.
My pager goes off. I pick up.
Yeah.
You page. What's the story with Mr. Cat?
Turtle clears her throat. You can hear the stress, but she forces herself into this professional cadence. "Good morning, Dr. Bear. I'm Turtle, the registered nurse caring for Mr. Cat in bed 4. I am requesting an urgent clinical review. Mr. Cat has acutely deteriorated. He has entered the yellow zone due to tachypnea and hypoxia. His current SpO2, his oxygen saturation, is 88% on room air, and he is showing severe signs of respiratory distress."
I'm listening. Go on.
Mr. Cat is a 65-year-old male admitted yesterday with an acute exacerbation of COPD. He has a 40-pack-year smoking history and long-term home oxygen use. His baseline oxygen is usually 92%. He has received his scheduled morning nebulizers, salbutamol and epitropium, but his condition is still worsening.
Right.
I have just completed a full A to G assessment, and here are the findings. I have already commenced 2 liters of oxygen via nasal prongs to maintain his target saturation of 88 to 92%. Turtle takes one more breath to deliver her conclusion. I recommend an urgent arterial blood gas, an ABG to check for CO2 retention, and a stat dose of nebulized bronchodilators. Would you also like me to order a portable chest x-ray and a small fluid bolus to address his low urine output?
Excellent assessment, Turtle. Your A to G was very thorough. The low urine output, combined with that tachycardia, suggests he's compensating hard. Let's get that ABG immediately. Bunny, stay with the O2. Keep it strictly between 88 and 92%. We don't want to lose his respiratory drive.
And scene. I mean, that is the handover. It is a remarkable psychological shift.
It really is.
Turtle goes from literally crying out for help to smoothly firing off this flawless, multi-step clinical report. She's anticipating the doctor's needs before he even asks.
Yeah, and the underlying architecture of that transformation is a tool called ISBAR.
ISBAR.
Right. For the nursing students listening, ISBAR stands for Identity, Situation, Background Assessment, and Recommendation.
Okay.
It is the gold standard for clinical handovers.
It seems to function a lot like a pilot's pre-flight checklist.
That's a great comparison.
Because when you have multiple providers and shift changes and emergencies happening, you just can't rely on conversational storytelling.
Exactly. You don't have time for a story.
Right. A framework like ISBAR forces an adrenaline-soaked brain onto a logical track. So you start with identity. Who am I and who is the patient?
Yes.
Then situation, why am I calling right now? Background, what is the clinical history? Assessment, what did I find? And finally, recommendation, what do I need from you?
And that structure entirely prevents communication errors.
Yeah.
It standardizes the expectation of what information is delivered and in what order. So the doctor knows exactly what's coming.
But, and this is a big but, the structure is really only as good as the data you put into it.
Oh, 100%.
Like Turtle's success relied heavily on using highly specific medical vocabulary to paint that picture.
Right. She didn't just say, he looks sick.
Exactly. And I think we should decode some of that vocabulary because for first-year nursing students or English learners, those terms can sound like a completely different language.
You really can.
Like, Turtle mentions that Mr. Cat was admitted with an acute exacerbation of COPD.
Right. So acute exacerbation. And that is pronounced acute exacerbation.
Acute exacerbation.
You got it. In medicine, acute means it is happening suddenly and severely.
As opposed to like a chronic thing that develops over time.
Exactly. Chronic is slow, acute is fast, and exacerbation just means a worsening.
Okay, so it's getting worse quickly.
Right. So an acute exacerbation of COPD indicates his chronic lung disease has suddenly flared up into an immediate severe crisis.
Got it. Then in her situation report, she notes he entered the hospital's yellow zone, which is usually an early warning track and trigger system for deteriorating patients, right?
Yes, exactly.
And she says he entered it due to tachypnoea and hypoxia.
Right, so tachypnoea, which is pronounced tachypnea.
Tachypnea.
Yes. The prefix tachy means fast, and noa relates to breathing. So it literally just means abnormally rapid breathing.
Okay.
And then hypoxia, hypoxe, that indicates low levels of oxygen in the tissues.
Wow. Okay, so when I hear those terms, my first thought is actually about the audience, like who she's talking to.
Goes so.
Well, if a nurse is talking to a patient or a patient's family saying tachypnoea and hypoxia would just cause total confusion, right?
Yeah, they panic even more.
Exactly. They would use lay terms. They'd say the patient has shortness of breath or low oxygen, or, they might say the patient is wheezing.
Right.
But Turtle switches to these multisyllabic Latin terms with Dr. Bear. It seems like this concept of language bridging.
Yes, language bridging is a huge part of the job.
Using precise clinical jargon to remove the subjectivity of a phrase like, oh, he's breathing fast.
You are hitting on a core communication skill in healthcare right there. I mean, medical professionals constantly translate between the patient's experience and the clinical data.
Right.
Like you said, when communicating with patients, a nurse absolutely uses lay terms. You ask if they are coughing up phlegm rather than asking for a sputum sample.
Right. Sputum sounds terrifying if you don't know what it is.
It does. Or you say wheezing instead of expiratory stridor.
Wow, expiratory stridor. That sounds like a sci-fi villain.
It really does.
Yeah.
But the lay terms are accessible. They're less intimidating. But with the doctor, breathing fast is just too subjective.
Because my version of breathing fast might be different from yours.
Exactly. Tachypnoea is a defined, measurable clinical state. And saying his SpO2 is 88% on room air gives Dr. Bear the exact objective data point he needs.
And room air is just the normal air we breathe in a room, right? Which is only about 21% oxygen.
Spot on. So stating his saturation is 88% without any extra oxygen support tells the doctor exactly how severely the lungs are failing at that very moment.
And that objective data is what allows Dr. Bear to make split-second decisions without having to ask, 5 follow-up questions.
And he doesn't have to guess.
So Turtle essentially acts as this bilingual translator, turning the messy reality of Mr. Cat's struggle into standardized data. And she strings those terms together beautifully during the background and assessment phases.
She really does.
But I have to say, the background details she provides are quite grim.
Very grim.
She notes he is a 65-year-old male with a 40-pack-year smoking history.
Yes.
Now, a pack year is a way to measure smoking exposure, right? So that could mean he smoked 1 pack a day for 40 years, or maybe 2 packs a day for 20 years.
Exactly. It's a cumulative measure.
But either way, it means significant long-term destruction of the lung tissue.
Yeah, and that specific detail tells Dr. Bear instantly that Mr. Cat's lungs are deeply compromised.
Right.
The alveoli, which are the tiny air sacs where oxygen actually enters the blood, they're likely damaged beyond repair.
Wow. And Turtle also notes that he already received his scheduled morning nebulizers, salbutamol and ipratropium, but he is still deteriorating.
Which is a massive red flag.
Right. Let's talk about the mechanics of those medications for a second. Because salbutamol is a bronchodilator, it physically relaxes the smooth muscles around the airways to open them up.
Yes.
And ipratropium dries up secretions and keeps those airways from spasming. So if those medications are already on board and they're actively opening his airways, but he's still suffocating, the problem isn't just a simple asthmatic constriction.
No.
The issue is much deeper.
And that deduction right there is exactly why Turtle performs an A to G assessment.
Right, A to G.
Yeah. For the students listening, that stands for airway, breathing, circulation, disability, exposure, and often includes further information and getting help.
So it's basically a systematic head-to-toe evaluation.
Exactly. It forces the clinician to look at the entire body.
Which prevents them from getting, tunnel vision on just the lungs.
Tunnel vision is a massive risk in emergencies. Because you see someone gasping for air, you naturally just focus on the chest.
Sure, that makes sense.
But because of that A to G assessment, Dr. Baer immediately zeroes in on two very specific things outside the lungs. The low urine output combined with the tachycardia, the fast heart rate.
And he says he's compensating hard.
Yes.
Which, when he says the body is compensating, it sounds like the body is actively triaging itself.
That is a brilliant way to put it.
If there's critically low oxygen, the body must be shutting down non-essential systems on purpose just to keep the vital organs alive.
That is exactly what's happening. It's the body's survival mechanism in action.
Wow.
When oxygen drops to crisis levels, the brain triggers a massive fight-or-flight response. The heart pumps furiously fast, that's the tachycardia, to circulate whatever low oxygen blood is left as quickly as possible.
Right, it's just trying to move what little it has.
Exactly. And at the same time, the body constricts blood vessels to the extremities and less critical organs to redirect that blood flow to the brain and the heart.
So the low urine output isn't a kidney problem at all.
No, not at all.
The body has literally clamped down blood flow to the kidneys, effectively turning them off to save the brain.
You got it. The
Yeah.
body is working overtime to compensate for the failing lungs. But, compensation can only last so long before the heart just gives out from the sheer mechanical strain of beating that fast.
So Mr. Cat is on the absolute brink of total cardiovascular collapse.
He is right on the edge.
Which makes the R in ISBAR, the recommendation, so crucial here.
Yes, the recommendation is where Turtle really shines.
Because she doesn't just call the doctor, list off a bunch of terrifying physiological failures, and then ask, what should I do?
Right.
She actively recommends an arterial blood gas, or ABG, to check for CO2 retention.
And an ABG is a critical diagnostic tool here.
How is that different from a normal blood test?
Well, unlike a standard blood draw from a vein in your arm, an ABG takes blood directly from an artery, usually in the wrist.
Oh, okay.
It is more painful for the patient, but it provides a real-time, highly accurate measurement of the exact partial pressures of oxygen and carbon dioxide in the arterial blood before it gets used by the tissues.
Wow, okay. So it's a much clearer picture of what the lungs are actually doing.
Exactly.
And she also recommends a portable chest x-ray and a fluid bolus to address the low urine output. Now, I'm assuming a fluid bolus is just a rapid infusion of intravenous fluids to quickly boost his overall blood volume?
That's the idea, yeah. Since the body is shutting down the kidneys due to perceived low fluid volume and low oxygen, giving a quick bolus of IV fluids tries to counter that shock state.
Makes sense.
It improves circulation without forcing the heart to work even harder to pump an empty tank.
That's incredible. Turtle is anticipating the entire clinical pathway before the doctor even has to issue the order.
She really is. It elevates her from being just a reporter of bad news to an active problem solver.
But as Dr. Baer agrees with her plan, he gives one final instruction to Bunny that highlights just a terrifying paradox.
Oh, yes.
He says, stay with the O2, keep it strictly between 88 and 92%. We don't want to lose his respiratory drive.
The oxygen paradox.
Yes.
It's one of the most counterintuitive concepts in respiratory medicine.
Yeah.
It's a critical learning point for any healthcare student.
Because the intuitive human reaction is to give a suffocating person as much air as possible.
Of course it is. Crank the oxygen to 100%.
Right. But structurally, Dr. Baer is saying that giving him maximum oxygen could actually be lethal.
Yes, it could kill him.
It makes you think of someone suffering from severe dehydration. Like if you find someone dying of thirst in the desert and you force them to chug a gallon of water, the massive sudden shift in electrolytes can actually trigger brain swelling and seizures.
Wow.
You shock the system with the very thing that is supposed to save them.
That analogy translates perfectly to the mechanics of COPD and CO2 retention.
Really?
Yeah. To understand why too much oxygen hurts Mr. Cat, we have to look at the brain's breathing triggers.
Okay.
In a healthy person, the primary trigger to take a breath is not actually a lack of oxygen.
Wait, it's not?
No, it is a buildup of carbon dioxide.
Okay, so CO2 acts as the gas pedal for the respiratory system.
Exactly. When CO2 levels rise in your blood, your brain senses the acidity and forces your lungs to take a breath to blow it off.
But Mr. Cat has severe chronic COPD. So for years, his damaged alveoli haven't been able to efficiently blow off CO2.
Right.
Meaning his blood CO2 levels are constantly chronically high. So if his CO2 is always high, his brain would constantly be screaming at him to breathe, which is totally unsustainable.
Right, he'd be exhausted.
So the body adapts.
Exactly. Over time, the brain realizes the CO2 alarm is broken. It's just ringing all the time.
Yeah.
So it resets its sensors and stops relying on carbon dioxide as the primary trigger to breathe.
Wow.
Instead, it switches to a backup system. It starts relying on low oxygen levels to trigger breathing. This is called the hypoxic drive.
The hypoxic drive. Okay, so the backup system only tells the lungs to work because it senses the oxygen is low.
Yes.
So if Turtle panicked, ignored her ISBAR training, and just cranked the oxygen dial all the way up to 100%.
His blood oxygen levels would shoot up to normal.
And his brain would see that the oxygen is totally fine, assume the crisis is over, and turn off the backup system.
Exactly.
It would literally stop telling him to breathe.
You flood him with oxygen, you completely remove his hypoxic drive, and he stops breathing entirely.
That is insane!
And because he stops breathing, the CO2, which he already struggles to clear, builds up to toxic, lethal levels in his blood.
Wow.
He slips into a coma, and the treatment becomes the very thing that kills him.
That is a terrifying paradox. But it perfectly illustrates why structured communication is so vital.
It really does.
Because Turtle performed a thorough A to G assessment, and because she communicated his specific history as a COPD patient, she knew to maintain his target saturation perfectly between 88 and 92%.
Right.
She gave him just enough oxygen to keep his organs alive, but kept it just low enough to ensure his brain kept telling his lungs to work.
It is a razor-thin tightrope to walk.
Yeah.
It requires deep physiological understanding and, honestly, more importantly, the discipline to adhere to protocols over panic.
Yeah.
That is the true value of the ISBAR framework.
We've covered a tremendous amount of ground today.
We really have.
I mean, we stepped onto the floor of the clinic. We watched a newbie nurse navigate the sheer panic of a rapidly deteriorating patient. We decoded the dense medical jargon of a respiratory crisis, learning how language bridging translates a patient's reality into precise, actionable data.
Scutum versus phlegm.
Exactly. We unpacked the intense physiological battle happening inside Mr. Cat as his body utilized compensation to shut down his kidneys and save his heart. And we explored the fascinating and honestly scary mechanics of the oxygen paradox.
And the ultimate takeaway for you listening is really about the universal application of structure.
Yeah.
You may never have to calculate the hypoxic drive of a COPD patient or administer a fluid bolus. But you will face moments of extreme pressure.
Oh, definitely.
You will face complex, high-stakes conversations where information needs to bridge a gap clearly and accurately under tight deadlines.
Right.
Having a mental framework, a structured way to organize your thoughts before you speak, is the ultimate tool for managing a crisis.
Which leaves us with a fascinating thought to ponder. If a simple 5-letter acronym like ISBAR can override our biological fight-or-flight response, organize massive amounts of complex data, and literally save a life in a chaotic clinic room, what other areas of your daily life are waiting for the right structural formula?
Oh, that's a great question.
Right. From navigating tense workplace conflicts to managing personal finances or even organizing emergency planning at home. How much disaster could you prevent simply by giving your panicked brain a track to run on?
Structure really is the antidote to chaos.
It really is. Something to think about the next time you feel the static creeping in.
Absolutely.
Well, thanks for stepping into the clinic with us today.